Welcome to all. I am Dr. Saravanan, Assistant Professor in Department of General Surgery. Today I have chosen the topic on diabetic foot ulcer. Ulcer is one of the important short cases for you kept in clinical examination. Diabetic foot ulcer is one of the types of ulcer that is commonly kept. Today we are going to discuss about diabetic foot ulcer. Before we go into our topic, first you should know how diabetes has affected our country. 80% of the patients who have been diagnosed to have diabetes are from low and middle income countries. India is now being the second largest diabetic capital in the world next to China. 69.1 million patients have been affected with diabetes. This data is slightly less compared to the real situation because due to underreporting of diabetic cases. The prevalence of diabetic foot ulcer in diabetic patients is approximately 4.5 to 10%, with overall lifetime incidence for developing a diabetic foot ulcer is 25%. So, patients who are being diagnosed to have diabetes are known to have one of the common complications called diabetic peripheral neuropathy and diabetic peripheral vascular disease that will predispose the diabetic patient to develop a diabetic foot ulcer. So based on the studies, it has been found that 30% of the patients who are diabetic and affected with peripheral neuropathy and peripheral arterial disease are over the age of 40 years. Let us go into our diabetic foot ulcer. Foot ulcer itself is worrisome for the diabetic patient and it is a challenge for the surgeon. Reason for that is because the most feared complication of diabetic foot ulcer is amputation, and diabetic foot ulcer accounts for 8 out of 10 non-traumatic amputations. It is believed that one amputation is occurring every 30 seconds in some part of the world is because due to diabetes. Why it is so important? When the patient is being diagnosed to have diabetic foot ulcer, it increases the morbidity, it increases the hospitalization rates and also the healthcare cost for the country. How diabetes is affecting diabetic patients and they develop diabetic foot ulcer. The most important part is for the physician who comes as the first line in treating the diabetic patients. So the moment a patient has been diagnosed to have diabetes, the physician has to do a complete examination of all organ systems. Along with that, foot examination is mandatory. So why? Because any patient who has been having diabetic peripheral neuropathy or peripheral arterial disease at one point of time will land up invariably to develop a diabetic foot ulcer at some region of the foot. So this can be prevented if they are being diagnosed early. How? Proper screening of the diabetic foot by examining the sensation, pulses and also the changes that has occurred already in the foot can alert the physician, can alert the patient that there is going to be a chance for developing a diabetic foot ulcer. Similarly, the patient should also be educated that the importance of self-examination of the foot using a mirror and also self-examination of their own footwear. The patient's diabetic footwear is one of the key protective mechanisms to prevent diabetic foot ulcer. Diabetic foot patients who are being diagnosed to have diabetic peripheral neuropathy and peripheral arterial disease should undergo a proper screening of peripheral neuropathy and peripheral arterial disease, and the footwear has to be designed specifically and individualized to each and every patient, and the footwear should be properly fitting and it should be appropriate for that particular type of foot. Patient should have 2 sets of footwear, one to wear inside the house, one to wear outside the house. Every time when they reach out for job and they come back home, they should do a self-examination of both their foot and their footwear. If they notice any piercing of thorn, nails or foreign bodies in the footwear, immediately they have to examine their foot. If they see some punctured wounds, bleeding, pus discharge or swelling, that immediately the patient should reach the nearest hospital and get the first aid done properly. Self-treating the diabetic foot is not advisable because it can delay the presentation and it can lead to complications. To an extent, it can land up in amputations also. Yes, let us see about the diabetic foot pathophysiology. As we said, diabetes causes increased blood glucose levels. If blood glucose levels goes beyond particular level, long-term complications can also occur. So, how it affects? Glucose when it is very high, it combines with amino groups of that is present in the intracellular and extracellular proteins to form Schiff base. The Schiff base will be converted to amidary products that will finally lead to advanced glycosylated end products. These advanced glycated end products are abnormal and they can cause molecular dysfunction, non-specific trapping and oxidative stress. Finally, to lead to increased amount of cytokine productions like interleukin-1, tumor necrosis factor alpha, and growth factors like transforming growth factor beta. And similarly, advanced glycated end products will act through receptors for advanced glycated end products, and it also further increases the cytokine production. What is the problem in this inflammatory response? This inflammatory response is going to produce abnormal cell growth and differentiation that can lead to abnormal matrix deposition in the kidneys that can cause damage to the glomerular basement membrane, and glomerular basement membrane, patient can develop diabetic nephropathy. Similarly, cell proliferation and differentiation which can also occur in the vessels of the retina and causes increased angiogenesis and leading to diabetic retinopathy. Similarly, high glucose levels can raise sorbitol by polyol pathway, increasing the fructose levels. Both can lead to increased advanced glycosylated end products, and it also sorbitol at very high levels are impermeable and it can cause lens swelling and finally development of cataract. Similarly, sorbitol can also decreases the mino-inositol in peripheral nerves, leading to peripheral neuropathy. There is one more mechanism by which peripheral neuropathy occurs. Decrease in nitric oxide and glutathione causes reduced vasodilation and decreased neuronal blood flow. This is mediated by phosphokinase C beta inhibition pathway, which can cause decreased peripheral nerve conduction, increasing the intracellular calcium levels and decreasing the sodium potassium ATPase pump, leading to again decrease in myo-inositol in peripheral nerves, causing peripheral neuropathy. So first, we should know about diabetic retinopathy. Diabetic retinopathy is also one of the complications following long-term diabetes. So how it presents? Initially, it presents as mild non-proliferative diabetic retinopathy where patients will have only microaneurysms. Similarly, when the patient next stage, they present as moderate non-proliferative diabetic retinopathy. They will have at least one hemorrhage or they will have microaneurysms, and they will have at least one of the followings, which include retinal hemorrhages, hard exudates, cotton wool spots and venous bleeding. Severe non-proliferative diabetic retinopathy can have any of the following signs, or with the following the rule of 4:2:1 rule. That 4:2:1 rule signifies that more than 20 intraretinal hemorrhages in each of the 4 quadrants, definitive venous bleeding in 2 or more quadrants, and prominent intraretinal macular aneurysm that can be seen in more than 1 or more quadrants is seen, or macular aneurysm or macular abnormality is seen in 1 or more quadrants. Then the last stage for which that occurs is called proliferative diabetic retinopathy, where there is neovascularization and vitreal and periretinal hemorrhages. Diabetic retinopathy, why it is important in diabetic foot ulcer? Patients who are being diagnosed to have diabetic foot ulcer, if they are having retinopathy, it has a poor prognostic factors, because those patients who are having retinopathy, it is known that microvascular complications can also occur in the foot that can impair the wound healing. So this image what we are seeing here shows cotton wool spots, microaneurysms and neovascularization. All these are all retinal changes that are occurring because of diabetic retinopathy. In this other image, you can see the normal fundus. Next, diabetic nephropathy. Diabetic nephropathy has four major components. One, abnormal matrix deposition in the mesangium. Next, glomerular basement membrane damage. Third is afferent arteriolar dilatation or hyaline cast deposition narrowing the afferent arteries. Because of that, there is abnormal angiotensin converting enzyme secretion leading to decrease in glomerular filtration rate. Patient will initial stages of nephropathy. Patient will be having only proteinuria. As the proteinuria progresses further, patient can develop decrease in GFR. As GFR worsens further, patient will have frank renal symptoms of renal failure, and at one point of time, if it is not corrected properly, patient can land up in permanent end-stage renal failure, which will go in for a renal transplant. Why nephropathy is very important in diabetic foot ulcer patients? When a patient is diagnosed to have nephropathy, it is very important to control the proteinuria in order to prevent the worsening of the renal function, because nephropathy is also directly related to the healing in diabetic foot ulcer, and patients who are having progressive nephropathy will have poor outcome in diabetic foot ulcer treatment. So this image shows the stages of diabetic nephropathy, and that image shows a pan showing a urine which is having a frothy foamy urine. So in stage 1 nephropathy, patient will have only renal hyperinfiltration. That means there can be increased GFR and there can be renal hypertrophy. That is stage 1, where the patient GFR will be abnormally high. The second stage, where it is called the silent stage, where there is renal hyperfiltration and there will be normal urine, albumin excretion rate will also be normal, and early histological changes, which is non-specific basement membrane. Basement membrane thickening is the first and the earliest stage seen in diabetic nephropathy. Then the third stage, there will be presenting with microalbuminuria, which is also diagnosed during screening examination. Then followed by histological examination can tell, biopsy can show mesangial expansion, glomerular basement membrane thickening and arteriolar hyalinosis. Then fourth stage is where there is overt nephropathy, that is where the proteinuria is becoming more prominent. Patient will be able to identify the proteinuria by the presence of foamy bubbles in the urine, and also patient will have symptoms of fatigue, and then patient will also have puffiness of the face, pedal edema will be there, fatigue will be there, and long stay when the renal function is declining, patient will develop chronic renal failure. Pathophysiology in diabetic foot ulcer, in how diabetic peripheral neuropathy, the most common pathway is the polyol pathway. Because of increased glucose, there is increased sorbitol and fructose levels. Finally, it can cause oxidative stress and damage to the neuronal system. It is also involved in increasing the advanced glycoside end products. That will also worsen the renal failure, retinopathy and nephropathy. So this is this picture what is showing here in the slide will tell you how neuropathy is affecting diabetic foot. So there are three neuropathies that are seen in diabetic foot. One is motor neuropathy, sensory neuropathy and autonomic neuropathy. Because of motor neuropathy, there is a foot deformity and biomechanical abnormalities. The shape of the foot itself is altered, pressure points are altered. Sensory neuropathy causes loss of protective sensation, and autonomic neuropathy will cause decreased sweating and the skin will be dry. All together will form a callosity at the higher where the pressure points are very high. So what is happening now is the patient is having an insensate foot with an abnormal pressure points, and the skin of the foot is also dry. So repeated trauma which the patient is not able to appreciate now causes minor frictions, and there will be a small hematoma that is occurring between the callosity and the foot. That hematoma can get infected and it can form microabscess. That microabscess can burst open to form an ulcer at the pressure point where the callosity was initially located, and it will finally produce a neuropathic ulcer. So the summary of pathways involved in diabetic foot: polyol pathway, exosamine pathway, protein C kinase beta inhibition pathway, and advanced glycated end products. All the four pathways are responsible for retinopathy, nephropathy and neuropathy. Patients who are developing retinopathy has it's been associated with poor outcome in diabetic foot ulcer. Patients who are being associated with diabetic foot ulcer patients associated with nephropathy is also having poor outcome. And similarly, patients who are having peripheral neuropathy along with peripheral arterial disease also affects the outcome in diabetic foot ulcer. So patients who are being diagnosed with diabetic foot ulcer should also be screened for nephropathy and retinopathy at the time of screening. Let us go into the examination of the diabetic foot. So like any other ulcer examination, a brief history taking is very important here, which includes the duration of the ulcer, discharge from the ulcer, foul smell, any foul smelling is there from discharge, the foul smelling discharge is there, then swelling of the toe, foot or leg, blackish discoloration of the foot or toes, limb pain, fever, chills, rigor, decrease in appetite, vomiting and decreased urine output. All these highlight histories are very important because it tells whether the ulcer is presented with a localized infection or generalized infection or sepsis. Apart from this, past medical history which includes duration of diabetes, hypertension, kidney disease, renal transplant, immunosuppressive therapy, steroid therapies, previous surgeries, previous amputations, and treatment history has to be detailed very well in all the diabetic foot ulcer patients to know what drug they have been initially been using, which includes the generic name of the drug, dosage, frequency and how long they have been using it. Then history of allergies has to be recorded, then history of immunization for tetanus and hepatitis B has to be noted down. General examination for diabetic foot patients, diabetic foot ulcer patient, the consciousness level of the patient is very important. Any patient who is been in sepsis or dehydration will be drowsy, disoriented or lethargic. Dehydration signs like sunken eyes, dry tongue, reduced skin turgor tells the patient is having diabetic ketoacidosis or hyperglycosuria. Then treatment temperature recording is very important. It tells you the sepsis features. Pallor indicates patient underlying conditions which includes renal failure, sepsis. Icterus examination is important to know whether there is any patient is having abnormal liver function that has occurred following sepsis. And the regional lymph node examination has to be done, that can be included during our foot examination also. Pedal edema is important. Pedal edema, if the edema is located confined to the infected foot, that is probably because of infection. Whereas if the diabetic foot ulcer patient is having bilateral or generalized edema, it is probably because of the underlying renal failure or or hypoproteinemia or because of cardiac failure. So that part has to be examined clearly, and pulse examination and blood pressure examination is important in diabetic foot ulcer patient, because in patients who are having diabetic foot and sepsis, it is redistributive shock, where patients will be having bounding pulse and hypertension will be there. Whereas in patients who are dehydrated, they will be having low volume 30 pulse with hypotension. Respiratory rate will be increased in diabetic foot ulcer patients if there is a presence of a sepsis or diabetic ketoacidosis. Let us go into the local examination of the ulcer. On inspection, you should locate the size, site, shape, margins, edge, floor, discharge and the surrounding skin of the ulcer. It will tell you what type of ulcer the patient is having. Suppose if it is occurring in the sides of the foot where the velcro straps are holding, it is friction related blisters that has formed ulcers. If it is occurring in the tip of the toes, it is because of peripheral vascular disease. If it is occurring at pressure points, it is because of peripheral neuropathy. This discoloration of the toes indicates gangrenous changes. The toes can be swollen, black, dusky. It can occur in the toes or in the heel also. Shape of the foot is very important to know whether there is any underlying charcot changes. Movement of the foot and toes is also important. Palpation, it is always done with a gloved hand with other universal precautions to be followed. Inform the patient what we are going to do. Then patient should always be examined in the examination table with good lighting. Localized warmth and tenderness has to be seen. That indicates there is an underlying inflammation or there is an underlying infection. Palpating the ulcer is very important. The edge induration tells you that chronicity of the ulcer. Floor has to be palpated for sensation of the ulcer. In case if the ulcer is deep and it is extending till the bone, that the sterile gauze swab or artery forceps can be used to probe the depth of the ulcer. At this time, I will always recommend you to take a swab for pus culture and sensitivity.